right, so this is a pre-recorded lecture on the CCRN exam prep. Presented by myself, Noah Dagan. I'm going to be doing this as a test run for my live class tomorrow. So please just bear with me if I have to do some cuts. And this is my first time teaching class too, so it'll be interesting. Um, I am a registered nurse in a medical ICU. I have about 2.5 years of experience, and I currently am a chapter president for the Heart of Carolina in Columbia, South Carolina. And that's an AACN group. And we do a lot of volunteer work and we host stuff like this. So I am excited to be kind of walking through how this exam is going to go and some things that you should know and things that you should study on your own as well. So we'll just start with the basics here. Things to know about the test itself. Just logistics of what is required to take it and how much it is, how to do all that. So you have to be a member of the National AACN chapter. I guess it wouldn't be a chapter, but an organization. And I believe that's $75 a year, or it might be for 3 years. You'd have to check because they might change it. But the cost of the test itself is $250, and some hospitals reimburse that. Some will pay for your study material. Some will pay you to just study for it, and then also pay for the test as well. But that's $250 if you have to pay for it out of pocket. There's 150 total questions, and 25 of which aren't scores. This is just similar to the NCLEX, where they have questions that they just need to evaluate and shift through. And so 25 of those questions are not going to be scored because they're testing to see if they're fair questions. And when I took it, it was a required of 83 of those 125 questions that are graded had to be correct. So that's about 66%. Which I think they've changed it in the past. It used to be 87. So when you look at the test manual on their website, just check that. Not that it really matters. You're gonna, by the time you're ready to take it, you'll score well above that. You have 3 hours to take it, so that's about a minute and a half per question. So plenty of time to sit, think, come up with a good rationale of why you're choosing your answer, and move on. Requirements: you have to have at least 1,750 hours of bedside care within the last 2 years. I had taken it, and you could take it within 2 years, but you have to have 1,700. And if you work full time, you'll get that within a year, no problem. I put that there. If you work full time, you get about 1,800 hours in 1 year. And then you have to renew it. They want you to keep up your knowledge, so you need 100 CRPs, that's continuing education recognition points, so hours that you've committed to continuing your education, and that can be done over the course of 3 years. So if you do the math, that's about 1.5, or it's about one every week and a half. But there are a lot of things you can do to get many of them. You can go to national conferences, you can teach classes like this, but I think with stuff like this, you have to apply for them or prove that you've done it. And that's only $150 to renew every 3 years. Okay, so let's see what a real life score report looks like. This is mine when I took it. And you can see different content areas: cardiovascular, respiratory. They lump endocrine and quite a few other categories, as well as musculoskeletal. And then the big section on the very bottom that a lot of people ignore, that you can get a lot of points wrong on, is that professional care and ethical practice. People think that, oh, that's common sense. That's just being compassionate, considerate. But once you start doing those practice questions with that, they can be pretty tricky, and they're really trying to look for you to give a certain answer for a topic. So I think the best way to do those questions is just to do a lot of them and read the rationale, and try to start to think like the test wants you to think. But that's mostly with just that section. The rest of them are pretty just critical thinking questions. You can see I got about 2 to 6 wrong in each section, and right here in the middle it shows your passing score and what you got, and I'll give you congratulations, and you'll find out immediately when you finish the exam. So what I always tell people is schedule it first. Just schedule the exam if you know you want to take it, and life is going to be somewhat open for the next 3 months. Schedule it because your brain will take over just like it did in nursing school, and you'll study for it. You'll do whatever it takes. But if you don't schedule, it'll be 3 years later, and you won't have not taken it. So schedule it. You'll be forced to study for it, and then you'll just take it. So what are the sections? What are these 156 questions? How are they broken up? Um, this can be changed and adjusted a little bit, so just check when you take it. But cardiovascular, this goes top down. So cardiovascular being the second biggest, professional caring is actually the largest. So you're going to get 130. You're going to get 30 questions of that. Respiratory and musculoskeletal, as well as multi-system, those are all going to have at least 20 questions, give or take. And then the next few sections that I'm actually going to start with is endocrine, hematology, GI, renal, integumentary. Each one of those sections only has 6 questions, so when you study those, what I tell people is study for the big stuff, right? If they got 6 questions they're going to give you for endocrine, they might not necessarily ask you a thyroid question. They might want you to focus on a diabetes or a SIADH question. So when I go through endocrine here in a minute, you'll kind of see what the big topics they're looking for. And what resources? Well, you're doing one of them. This is great. To listen to a recorded or go to an in-person exam review is awesome. I listened to a Laura Gasparo video, and that helped me a ton. And you're listening to this, but it's not the only thing. People come into these sometimes and they think that, I'll just listen to this review and I'll go take my test and everything will be great. But there's so much content that I can't cover it all. I'll mention some of the things that I want you to study that I can't cover. And these books are going to help you a lot. So this top left one, that's what I use, the Barron's Adult CCRN exam. It's got 3 practice tests and a pre-test in the beginning. So you take that pre-test, you get a gauge of where you're at, and then you take those full-length tests and kind of follow along. And then Nicole Kupchik's, she's got a book. I never read it or bought it, but a lot of people swear by this one as well. And you can just get those on Amazon or at like a library maybe even. And then this one is big for me. I used a practice question book. So I got a book with another 2 or 3 tests, and those rationales are those huge parts in helping you understand. You'll get a base knowledge by just reading the book and listening to this lecture. And then when you take those practice questions, you really kind of smooth out where your missing gaps of information are. So definitely buy one of these top and definitely a question book with a couple tests in it, and it could be whatever you feel like buying, but I think that's the absolute minimum. So yep, start with this or that, do the pre-test, find out what your percentage is, and don't feel bad about it. Okay, don't beat yourself up and say there's no point in taking this test. I only got 43% correct. But track it on a piece of paper, on a sticky note, and then go on to the material and just start with the easy material. This book, this Barron's book, starts with cardiac, and I think I went through the book 3 times and just put it away because I started with cardiac every time, and it was way overwhelming. So you got to start with the easy stuff, okay, to kind of work yourself up, and end with the big heavy stuff like cardiac and respiratory because it'll burn you out. All right, you want to have that big heavy stuff at the end closer to when you take the exam. What I did and what worked great for me is you read a section, you don't rewrite anything, you're not taking notes, you just read the book. and then you take all that information in, and then you just start taking those practice questions slowly, right? You do a question, you do like 10 questions after that little section, and then you review that and you say, "Oh, okay, I remember reading that, but I got the value wrong, or I said hypoglycemia instead of hyperglycemia." Okay, that makes sense. And that rationale is really going to correct all that false information that you kind of suck in with your brain, and it's going to kind of smooth that out. So then when you eventually take uh, when you take a full length test at the end of the book, you're going to be a lot happier with your results. Okay, so how do I plan to review this? Again, I'm going to start with the easy stuff and kind of build up. And most of these topics you'll probably have seen in practice. If you work in cardiovascular, you're going to see a lot more of that, but you'll see a lot of this other small stuff. Just because a lot of patients come in with diabetes, a lot of patients come in with blood loss and GI problems, and they might not necessarily just be in a medical ICU. So this first day, I'm just going to talk about the exam and endocrinology, and then we'll do hematology and hemodynamics. I won't be teaching multi-system or cardiovascular, but I'll be teaching GI, GU, neuro, and respiratory. So I'll record all those beforehand, and yeah, it'll be a good time. So again, just review that exam handbook from the AACN website. That'll kind of give you a complete understanding of the exam if you want to know more about it. And then we're just going to focus on main topics. There's all sorts of endocrinology. There's all sorts of respiratory you could go into, deep dive. And if you get too deep on stuff, it won't be on the exam, and you're going to feel bad about it because you studied all this stuff that's not even on the exam. I really want you to put most of your time into rationale, because that's really what's going to help you out. So day 1, endocrine. We're going to talk about SIADH, diabetes insipidus. Those two kind of go together. They're like polar opposites. And then we're going to talk about hypoglycemia and DKA and HINC, hyperglycemic hyperosmolar non-ketonic coma. Those are high blood sugar. Hypoglycemia is low. So we'll just jump right into it. Again, endocrine's only going to be 4% of your exam. So 6 questions. There's 5 topics here, right? There's a lot more endocrine I'm not going to talk about in that. The books will mention just slightly, but most of your 6 questions are going to be in one of these 5 categories. And they're going to ask you a question about each one of these at least, just because there's so many patients that come in with this. They want to check your knowledge a little bit. So the first one we're going to talk about is SIADH. And with all of these topics, even if you see a bunch of text on the slide, I want you to know that I'm going to go through it all very slowly, and we're just going to start from the basic steps, so that way you really understand the why behind why these things happen. And I'm not just going to give you stuff to memorize, because I don't think that that's really what helps us in the ICU. I think that when we understand what's going on with our patients, we can really solve problems a lot easier. And that's essentially what questions are on this exam, is solving problems. So yeah, what we're going to start with, just what's the normal physiologic response to the concentration of blood, right? That's what our serum osmolarity is. Serum osmolarity is how concentrated your blood is. Okay, so normally it's between 275 and 295 milliosmoles per liter. Okay, now it's really highly regulated by the kidneys, but there's a big step in between how the kidneys regulate the concentration of your blood. And it starts up in your brain with these osmoreceptors. That's what are these little receptors on the right here. So they're going to be set. They're going to really be set and happy at a normal concentration between that 275 and 295. But as that concentration goes up, and let's say maybe a patient's been on diuretics and they're peeing a lot, so their blood is more concentrated. these little osmoreceptors are going to respond to that by shrinking. They're going to give the fluid that's within them out back to the blood. Now, it's not really going to solve the problem, but what it's going to do is shrink these, and it's going to send more impulses down the wire, and it's going to release vasopressin. Okay, just remember that it's going to release vasopressin because it's shrunk. It shrinks so it has more ability to send impulses down these channels. Okay, and the opposite is true when the blood is very hypotonic. These the water is going to swell into the osmoreceptor. This is all in your brain, by the way. It's going to go into your osmoreceptor, and it's going to close all these little gates because it's going to shut them. It's going to swell this neuron, and it's going to shut them, and it's going to make less impulses, which is going to mean it's going to release less vasopressin. Okay, this is kind of how it works down here. When it shrinks, these open. When it's swollen, these close. Okay, and vasopressin is going to work in the kidneys by adding little pores. It's going to add pores to the distal convoluted tubule. Okay, now you don't have, they're not going to ask you a question, exactly on the physiology of this, but it really helps to understand why it's happening. Okay, just the basics that when your blood's concentrated, your body's gonna release vasopressin, and vasopressin is an anti-diuretic hormone. It's gonna add aquaporins, pores, to your kidneys, and it's gonna retain that water. So all that urine, all that water that would exit in your urine, vasopressin is gonna save that water by adding pores so it pulls it back into the body. Okay, vasopressin also works on the heart, blood vessels, liver. It works on a lot of stuff. That's why we give it as a pressor in the ICU setting. So when we look at SI-ADH, we're looking at too much vasopressin. Some sort of thing is happening within the body that's releasing vasopressin and causing the retention of water, even though the body really doesn't need to retain it. Okay, one of those big things is oat cell carcinoma. That's little oat-shaped cancerous cells in the apical, the top portion of your lung, and those have been found to just be releasing vasopressin. Another thing is viral pneumonia. The body senses the state of hypoxia, and they found that patients with viral pneumonia often, or not often, but sometimes go into SI-ADH because the body's trying to better perfuse this hypoxia and resolve this hypoxia. Another thing is head trauma. So you want to think anything that causes an increase in pressure that eventually causes a squishing of those osmoreceptors, right? That's when vasopressin is released. So if you have some sort of mass that squishes these receptors and they release more vasopressin, then you got to resolve that. These last two aren't as common, but thiazide diuretics and high-dose vasopressin, that last one's kind of obvious, but they can also kind of either mimic or force the issue of retaining water. So what are the big problems with too much ADH, too much vasopressin? Well, when you have an increased retention of water, you have a dilutional hyponatremia. When you're retaining more water, you still have the same amount of sodium, but it's diluted. So it lowers that level. And when you have lower sodium, you have a lower seizure threshold. Okay, you got to think about action potentials. So big thing with cardinal problems with SI-ADH, you want to think seizures. Obviously decreased urine output. If you're not excreting that water, if you're holding on to it, your patient's going to be more oliguric. This one goes back to the first point here, decreased sodium and a decreased serum osmolarity. Those are lab values you can actually check and confirm your suspicion for SI-ADH. And then an increased blood volume, right? Because you're retaining all that water, so you'd have a higher blood pressure. So what do we do for these patients with SI-ADH? Well, we got to address the problem. If it's a viral pneumonia, give them antibiotics, or not antibiotics, antivirals. If their ICP is extremely high because they have this high retention of water or brain trauma, you want to correct that with either an EVD, or they might have to even go for craniectomy. If it's a tumor, then you can remove that tumor. And since they have all this retained water, and if they have a high blood pressure, you might need to suggest restricting fluids. Okay, they might still be conscious and just wanting to be, eating and drinking like normal, and they might have to be on a liquid restriction, or if you can concentrate medications, then you need to do that. And if the sodium falls below usually 120 is when we start getting worried about seizure threshold, then you can add a 3% drip. So next we'll talk about diabetes insipidus. Diabetes means excessive urination. So in this case, you're going to see these patients put out 6 to 20 liters a day. And I mean, their urine will practically look like water, that clear. And insipidus meaning lacking of. Okay, what are we lacking of? This is the opposite. We're lacking vasopressin. Okay, this relates all back to what vasopressin does. No change there. If we don't have vasopressin to retain the water, then we're going to lose the water. So what can big causes of this? These are just like head trauma can squeeze more vasopressin out. Then it can also cause a reduced amount of vasopressin. So if there's something that's preventing some sort of mass or swelling that's preventing vasopressin from entering the bloodstream, then you have that problem. Other thing is anticonvulsant, phenytoin, and that blocks sodium-dependent action potentials in the brain to stop seizures. But at a cost, you slow those action potentials down of those osmoreceptors. And that's going to decrease the amount of vasopressin released. So big problems with diabetes insipidus is you're going to have a decreased urine specific gravity. Okay, normal specific gravity is 1.010 to 1.020, 1010 to 1020. You can draw that by just sending urine to the lab. You're going to have an elevated serum osmolarity, right? If you're putting out all this water, your blood's going to be more concentrated. You're going to have an elevated serum sodium for the same reason. And these patients are going to be in hypovolemic shock, right? If you're putting out 6 liters a day, most people don't even get the recommended 2 liters a day. So you might have to give them boluses to replace that. And probably not normal saline boluses. And then you can get some ST depression too. So what is the treatment of diabetes insipidus? Well, the first thing is to treat the hypovolemic shock, right? If your patient has no volume, then replace the volume. You want to monitor for cardiac ischemia, and it kind of plays into the next reason, vasopressin, right? If your heart has no volume, if it has low preload, and it's working a lot harder from some of the vasoactive medications you're doing to keep the blood pressure up, then you could start to see some cardiac ischemia. It's working too hard. So what you want to do is you want to track your urine output, and they'll sometimes do this with like a 24-hour urine, and you want to keep checking the specific gravity, and in the meantime be solving the main problem of why do we have this diabetes insipidus. So those are two of the big ones, SIADH and diabetes insipidus. Those ones you don't see that often. So we got through that, and we'll move on to some of the more easy stuff. Hypoglycemia. We treat this a lot. We know what to give. We know how to recognize it, but what I want to emphasize is there's two big categories of symptoms you see from a lack of glucose. And I want you to guess before the next slide which one comes first. You've got your cardiovascular problems. Your heart doesn't have the sugar to work like it wants to, so you're going to get tachycardia. You're going to get palpitations. You're going to get sweaty, irritable, and restless, right? The brain doesn't have oxygen, or the brain doesn't have sugar, and you're going to start to see that. You start to get irritable because you feel bad. And then you have your central nervous system problems. You start to get confused. You start to get tired and lethargic. You start to have slurred speech. You come in with seizure-like symptoms or a coma. Sometimes you get elderly patients who come in from the nursing home to the ER, and they're hypoglycemic, and everybody's running around. They're having a stroke. Get them to the CT scan. They're having a stroke. ER is very good about checking the blood sugar early because we know that these central nervous system problems come from a lack of sugar, right? So I want you to guess which one comes first and maybe why. And then when you're done that, I want you to think about why would these cardiovascular problems be masked by a certain drug? What kind of drug would be masked in a drug that many people are on? Okay, what drug would that be? So if you guess cardiovascular, then you're right, because what's going to end up happening is you're going to see these symptoms as the body starts to release more epinephrine, right? That little organ right above the kidneys is going to release epinephrine because it senses it needs more sugar. It's going to go to the liver and inspire gluconeogenesis, but it's also going to cause tachycardia, and you're going to feel that, and you're going to see that in your patients. Now, what's very dangerous is when you get beta blockers involved, right? Because it's going to mask a lot of these symptoms. It's going to have a lot of negative beta activity. So if you have a patient who's coming in, or your patient in the ICU already is starting to become tachycardic, that's great. You can resolve it. You could say, oh, maybe I should check their blood sugar. They've been off tube feeds for the past 12 hours. I didn't think about that until I saw their heart rate and saw that they were sweating a little bit. So you get that and you check and you fix the problem. But then your other patient, your other patient is also hypoglycemic, but you just gave them a beta blocker 4 hours ago. And now they're lethargic, and I just don't understand why they're so tired today. Then you check a blood sugar, and it's in the, in the 60s. So, yeah, watch anytime you have a patient on beta blockers, just be careful of that. And then you treat the patient as they can tolerate that. If your patient's intubated, then it's going to be a lot different than your patient who's conscious and who can swallow. So you want to kind of follow the 15 by 15 minute rule. You want to get about 15 grams of carbs and then check again in 15 minutes. That's oral. Okay? You want to give complex carbs with protein because protein's a reserve energy former. You can break proteins down and they'll be a more long-term source. So you want to kind of get that into the body if they really haven't been eating. So no breads or candies. That stuff's going to be used up immediately. You want to get more carbs that are complex, so like multigrains, multigrain breads, different than just like your white bread. Not crackers. Crackers aren't always just the best, but that's usually what we carry. If they can't do that, then you can always do glucagon. Glucagon is normally in your body. It's a catabolic hormone. So it's going to work in the liver and break down all that glycogen. You can give that in the shoulder. You can give it sub-Q. It's also going to decrease GI motility. So if they have eaten something, it's going to have more time to be absorbed. And it's going to work in about 30 minutes. So it's not always the best if they're very low already. And then of course we all know D50. There's 25 grams of glucose in there. So you'll see a higher spike if you give an AMP of D50. Okay, so that was low blood sugar. Now we're going to talk about high blood sugar. So this is primarily caused by complete lack of insulin. Okay, DKA is primarily caused by complete lack of insulin, and you'll see that a lot in your type 1 diabetics, right? They just don't make it, or they don't make it a lot at all. As well as your pancreatic cancer patients, all those cells have died or can't release their insulin. And usually their blood sugar is above 300. And it's funny, why do we see that, right? Why do we see our patients with DKA come in with a somewhat lower blood sugar than somebody who comes in with HINC, where they can have a blood sugar up in the above 1,000? And usually because it's a much faster progression to coma, right? These patients that come in with DKA don't always have insulin, whereas the ones who come in with HINC, you'll see they have insulin, so that kind of draws out how sick they get. But in this case, they get sick very quickly. And when you have a lot of blood sugar, it causes a high urinary output. So you're going to see them be very dehydrated on top of this. That's why we give them fluids. Another reason why we give them fluids. And then as a result of not having insulin, you go into a state of acidosis. Your body starts to go into, it starts to burn up your fats, and starts to burn up your proteins, and you start to get ketones. And that's why they call it ketoacidosis, because all those acidic proteins are breaking down. So what I want to emphasize here is the relationship between insulin and glucose. How does insulin work, right? Because we don't really always think about that. We know insulin, helps glucose go into the cell, right? Insulin is just a trigger molecule. It binds to the exterior of the cell, and it triggers the creation of more channels. Okay? So insulin tells the cell, hey, you need to make more channels. You're not getting enough. We got too much blood sugar. We got too much sugar out here. And that's going to cause these little transporters to suck glucose up into the cell. And if there's too much of it, then it's just going to store it. But if the cell needs it, then it's going to use it. So the next thing I really want to talk about and put a lot of emphasis on is this relationship between our pH change, which is corrected when we give insulin, because we're no longer using fatty acid oxidation and ketones to get our energy. We're getting back to using glucose, so our pH is slowly going to return to normal. And that relationship with potassium, we need to have as much emphasis on checking and monitoring our potassium as we do running into the room and getting our blood sugar at every hour for glucomander, right? That's because for every drop in pH, for every 0.1 drop in pH, you should expect a 0.6 rise in your potassium. And that's a lot. Okay? You get a patient who's severely acidotic who comes in with a very high pH. You get them on dialysis, you correct the pH, or you correct the potassium, and then as you use insulin to correct the pH, the potassium all of a sudden is extremely low, right? Because it goes the opposite way. As you start to rise your pH back to normal, the body takes back that potassium and puts it back into the cell, so it lowers it even faster. So when we're correcting our blood sugar with insulin, we need to very closely watch this potassium, okay? We need to understand that what's so dangerous about a sudden drop in potassium, what's dangerous about a low potassium, what's dangerous about a high potassium, and keep an eye on that and start to sense that, oh, this patient may have been hypokalemic, and we're only seeing a high potassium because all that potassium was already in the cell, right? This potassium wasn't in the bloodstream to begin with. We need to give them more. It's almost counterintuitive, but that's what saves people from having these cardiac events. And when you see this hyperkalemia, you're going to see these high PT waves. You're going to see a widening of your QRS, and you'll probably learn this more in the cardiac section, but I'll just kind of touch on it briefly. But potassium determines the number of sodium channels. Sodium is regulated by how much potassium is in the cell. Okay, so the more potassium you have, the less channels of sodium you have, because it's trying to self-correct. So a high potassium, you're going to see these peak T waves, and if it gets worse, eventually you're going to have this be so wide where you have such a deep cut in your QRS and a deep rise in your T wave that you're going to get this sine wave. If you remember back to algebra, what a sine wave looks like, and it's going to paralyze the atria. You're going to get a heart block because there's so much variance in the action potential, and eventually that heart block just leads to asystole, right? So that's why we fear high potassium. And for the opposite, what happens to hypokalemia? Your T wave goes down, you get this ST depression, and then you start to get this U wave. Okay, so a low potassium, you're going to get a faster depolarization, and especially in the Purkinje fibers. The Purkinje fibers are so dependent on potassium that you're going to start to see PVCs. You're going to start to see, if it gets bad enough, VFib, V-flutter. And then I've actually had a patient who died because of the RNT. You know, we started correcting. They needed dialysis for a different reason, and then their potassium went way too low, and then they went into this RNT and passed away. So it's important both ways. If you start to correct things too quickly and you don't catch the hypokalemia that's going to happen, then and you can get very dangerous situations. So what I suggest is watching this video here. There's a ton of great videos on hypo and hyperkalemia that explain it way better than I do, because it is a very dense and kind of untangible thing to understand. You know, with pancreatitis, you can kind of see a lot of the symptoms of that. You know, any kind of trauma, you can see the symptoms and you kind of understand what needs to be fixed. But this is very 2D. You got to kind of understand this based on numbers and charts. So go ahead, watch this video, and it'll explain it a lot more. Okay, so what do we do with our DKA patients? Well, we always want to start with insulin replacement. Okay, you want to start to trickle this blood sugar back down. You want to get them out of this almost anaerobic state of using proteins and fats as a sugar source by giving them insulin back, which they can't produce most of the time. So you start to get that going, and then you correct your intravascular dehydration from the high blood sugar, and you can do that with normal saline if their blood sugar is high, or if their serum sodium is high and you're trying to avoid potential seizures. Then you can do half normal saline, right? And then you want to avoid that rebound of hypoglycemia by adding D5W to your normal saline. So it's going to kind of buffer, it's going to cushion that fall that insulin's causing. And then you always keep an eye on your potassium, and you can add that either 20 or 40 milliequivalents to your D5 normal saline, D5 half normal. And if they need more, then you can give them more. You know, the 20 milliequivalents every 2 hours. And that's kind of how you correct DKA, but you guys know that because you've probably had it 100 times. And a big thing that we have, as nurses with Glucomanter, have kind of gone away from knowing about is this: how quickly do we want to drop blood sugar? And that is all goes back to potassium. You know, the faster we're dropping this, the faster we stop using ketones and we start going back to our normal pH, the faster our potassium is going to drop. So we want to kind of go slowly for that reason. Also, because we don't want to drop too quickly. So the CCRN book will tell you drop your blood sugar between 50 and 100. So expect a question, saying, over the past 2 hours, your patient's gone from a blood sugar of 450 to 2010 or 210. And you're going to think, oh, that might be too much. We might be going down too fast. So decrease the insulin drip. Now that's kind of old school because now we use glucometer. It kind of calculates everything, but you still got to think about how fast is my blood sugar dropping because the test still wants you to know why. It doesn't want you to have the machine or the program, the algorithm to rely on. All right, so for the next part, we're going to talk about HINC or hyperglycemic hyperosmolar, so highly concentrated blood, non-ketotic coma. So your body's not using necessarily ketones or creating ketones from other energy sources. So what's this primarily caused by? Is it caused by a decreased presence or receptiveness to insulin? So more so your type 2 diabetics, your more elderly patients who come from a nursing home, and they're going to have much higher blood sugars because their own insulin has buffered them, has prolonged their progression and delayed their hospitalization. They should have been here a while ago, but they're now coming in with these extraordinarily high blood sugars because, now we're starting to see that they're having symptoms, right? This insulin has buffered it enough to where it's masked the symptoms. And what happens when you have so much sugar in your blood, you're going to have a high urine output. Just from osmotic diuresis, you're going to have this sugar pull in water. It's going to cause your cerebral dehydration. And that's where you're going to start to see your confusion. Okay. So you want to look for an elevated serum osmolarity with these kinds of patients. You're going to see it well above that 295. Okay, and one of the most important things is to replace that volume. Right, all that sugar is pulling out that volume, and the kidneys are still working fine. They're pulling all that volume out of the blood because they said, from their perspective, it doesn't need that volume. Okay, so that's one of the, as opposed to DKA in HINC, one of your most important things is making sure they're not hypovolemic, and then you're going to start that insulin therapy. With the same deal, drop your blood sugar by 50 to 100. It's going to take longer potentially, but they're going to have their own insulin to help. And you might have to still watch for their potassium, even though they might not be acidotic. You still might have to watch that. And so a big thing that can bring these things on are diseases that cause a lot of sugar to be required in the first place. So your pneumonia, your UTIs, and these are especially present in your elderly patients. A lot of the ones that come from nursing homes or who aren't being checked on as much as they potentially should be. Okay, now we'll go through these few clinical questions. And so the first one being, what is the effect of vasopressin on urine formation? How does vasopressin affect urine formation? I'll let you read and think about it for a second, and we'll kind of discuss the rationale behind the correct answer. Okay. So when we see this, we think, okay, vasopressin goes to the distal convoluted tubules and it causes more aquaporins to be added, which pulls water out of the urine that's being produced. So what we do is we retain the water and subsequently concentrate the urine, right? Vasopressin is going to bind to these receptors on the distal convoluted tubule, which triggers a protein to produce those pores. and that's going to cause the retention of water and concentration of urine. Which finding of the following laboratory values would be present in a patient with SIADH? This is one of the first things we talked about. So what would the laboratories be of someone who's experiencing SIADH? So they're probably going to have very dilute, or they will have very dilute blood, right? We're retaining water. So the serum osmolarity, the serum sodium is all going to be low because it's going to be very dilute. Okay, so what we'd expect to see is that low salt level, right? We wouldn't expect to see a high serum osmolarity. We would expect to see a high specific gravity, right? Very concentrated urine. And we'd expect to see a high urine osmolarity. For these ones are essentially the same, these two, C and D. So we would expect to see a low hyponatremia, dilutional hyponatremia. That's the big thing with SIADH. That's probably what you're going to get as a question is the patient has dilutional hyponatremia, and that's caused by SIADH. So as a charge nurse in the medical ICU and wherever you are, you review your 4 patients recently admitted. You're just checking in on them. And which of the following would you be most likely to expect to develop diabetes insipidus? Who would you expect to be the most likely to develop DI? Okay. So this is a question of causation. So we want to think of what causes DI. We also want to think about what causes SIADH, right? Because we're seeing things in here that cause SIADH. So we don't want to get those two mixed up. Okay, so viral pneumonia, we know that can cause more vasopressin or mimic vasopressin, just like thiazide diuretics can. Or a patient on a vasopressin drip with esophageal varices, right? More vasopressin, but we know DI is a low vasopressin. So what could be something that causes that is a potential head trauma. Could be blocking off that vasopressin from being utilized in the first place. If you're curious about why vasopressin's given to people with bleeding esophageal varices, because it works on the splenic arteries. So it works on all those arteries within your gut. So that's why we sometimes give vasopressin to people with varices. Okay, so we're doing well so far. What now you get a type 2 diabetic patient with severe hypoglycemia. And they're likely to present with a coma if they're on which of the following medications? So they present to you in a state of a coma. What medicine do you think they're probably taking? Type 2 diabetic. Right. So if you're thinking metoprolol, you're right on, because if you have a hypoglycemic patient, then it's potential that they came into the ED on a beta blocker because the family suddenly found them lethargic and confused and almost in the state of a coma. And now they're here to you in the state of a coma, right? Because all of the sympathetic symptoms have been blocked by the beta blocker. So all those cardiovascular effects we talked about are blocked by that beta blocker. Okay, which of the following laboratory findings is not likely to be seen in patients with DKA? Which of these lab findings would you not expect to find in someone with DKA? Okay, well, we see here we got a low pH and we've got a high potassium. That makes sense, right? Those we would expect to see if the patient hasn't been corrected yet. They don't necessarily correlate, but they're just two different values. Now, what's something that DKA patients do a lot of because they have all of this acid? What are they trying to do? They're trying to correct that acid by hyperventilating, right? So the respiratory system tries to raise your pH by blowing off CO2. Okay, it's trying to correct that pH imbalance somehow. And it does that by blowing it off, dropping it. A patient comes in with a blood sugar of 450 and a potassium of 4.5, an initial pH of 7.15. She started on an insulin drip, given a couple liters of fluid, and now the blood sugar is 215 and the pH is 7.32. So we don't know how long it's been, but we assume that it's been an appropriate decrease in blood sugar over time. That could be another question on the exam, just to watch to see how fast the blood sugar decreases. So which of the following would be appropriate at this time? Would you change the IV solution to a lactated ringer? Would you request the addition of potassium to the IV fluid? Would you give sodium bicarb? Or would you increase the insulin infusion rate? So because this isn't a time-based question, they didn't give us how long it's been since she's corrected this far, you can get rid of that last infusion rate question or answer. Right? We haven't talked about anything about changing fluid, so there's no need for that. You can get rid of A. And we don't correct the pH with bicarb because the pH is a problem from utilizing ketones as a source of energy. So we want to have them add potassium to the IV fluid, right? If the potassium started at 4.5, that's already low, right? That's very, very low for someone with a pH of 7.15, right? That patient has to go up 0.3 pH to be back to normal, 0.2 to 0.3 pH. So let's say it's 0.2. Let's say it's the low end. You're gonna decrease your potassium by another 1.2. So now your potassium's 3.3. That's just on the low end of when you check it again. So they definitely are already hypokalemic, but it seems higher. It seems normal because all of that potassium from inside the cell is in the blood vessel, but it's gonna go back. So you got to give them more potassium. Okay, a patient was admitted with DKA in the following lab values: a blood sugar of 515, sodium of 151, pH of 7.19, and a potassium of 5.6. They were started on an insulin drip, given a couple liters of fluid, and started on a continuous normal saline infusion. 2 hours later, the labs are as follows: a blood sugar of 212, a sodium's 156, pH of 7.34, potassium of 4.7. So what do these lab findings and the change in lab findings suggest you adjust? Now I'll give you a second, and for these questions you want to have a piece of scratch paper, and they'll give you that, to kind of count out your lab values. Okay? So go ahead, read the answers and pick one of those there. Okay? So this question's a little bit harder, right? Because you're looking at four different things, and you're also looking at them over time, right? So the big one, the first one, is it's been 2 hours and the blood sugar's dropped by almost 300, right? That's about 150 an hour, and we know we don't want that to drop anything over 100 an hour. So we need to decrease the insulin infusion first. Okay. Second thing is, over 2 hours, their sodium has gone up 5 points. It doesn't seem like that much, but over 2 hours, it could keep going up. So definitely want to change that to a half normal saline and see if that helps. Okay. So the right answer would be C. Okay, but this question kind of tricks you because it gives you the pH and it gives you the potassium, but those have been changing at a stable rate, right? The pH is almost back to normal, and the potassium isn't low. Okay, so we don't need to necessarily add potassium. The patient maybe was hyperkalemic beforehand, which helped them in this case, not needing extra potassium. Right. So yeah, that's a trickier one, but it feels good to kind of solve those problems just from lab values and time, right? Because nurses are primarily responsible for reading these lab values and interpreting them and catching things in the moment before they go on for another hour or 2 hours before, our resident or doctor gets time to review them. So these are definitely things that you're going to be able to catch with your own patients and say, oh, this is changing too fast. Okay. So a 68-year-old is admitted with a blood sugar of 1200. She is severely dehydrated, has shallow breathing at 18 breaths a minute. And so what would you first expect with this patient? Okay. So this one could be a little tricky too because of that letter C there, saying either of the above, right? In HINC, we have high blood sugar. In diabetes, we have high blood sugar, right? In diabetes insipidus, we have severe dehydration. But the thing we're really looking for is that breathing. That's going to kind of rule out those other answers. Is that with a patient in DKA, you may almost always see them with the higher respiratory rate. Okay, because they try to reduce that acid load. Whereas people with in a state of HINC are going to have a lot smaller, shallower breaths. It's important for the nurse to identify those patients predisposed to HINC. So, which condition or therapy would not predispose a patient to developing HINC? So, three of these you would likely see with the patient coming in for HINC. Okay, this one might be a little bit easier. You probably wouldn't see someone come in with a CVA or someone who's having a CVA who's developed HINC, right? HINC is something that takes time to develop usually. So as a patient ages and they lose insulin sensitivity, or in the state of pancreatitis, where they don't have as much insulin to be utilized, or um, a TPN infusion where they're constantly getting blood like a sugary infusion that's causing them to require more insulin that could potentially put them in a state of resistance. Okay. And that's it. That is it for endocrinology. A lot there, but again, you only have 6 questions, right? We went through about 9 there. So you just think probably get 1 or 2 questions on diabetes insipidus or SIADH. Probably going to get a question on hypoglycemia. And then you'll probably get a question or 2 on DKA and HINC. So just go back through this video if you want, or go through your study materials for sure. Do lots of questions and just think, what are the big important things that we talked about with those 5 conditions? And just commit those to memory and really practice that rationale to understand why the things are happening. And you'll get all of those questions right, or just miss a couple, which isn't a big deal. So, and yeah, that is the day 1 for the CCRN review. I'll record the second one here shortly and upload that. And thank you. Thank you for being patient with me and sticking through and going after your professional development. That's awesome. You're definitely going to do your patients a service. So thank you.